March 15, Wednesday, Lunch and Learn. We're going to keep everybody muted for a bit because we have a guest speaker and we're still working with this whole system of muting and unmuting, and sometimes it's hard to find who's making noise. So towards the end of today's session, Richard will begin to unmute people, and then Dr. Frey will take questions. I'm not going to do a lengthy introduction. I'll let Dr. Frey sort of give you some more background on herself, but over the past couple of years, I first met Dr. Frey at the ISNR conference that was held in Denver, Colorado, and she's with the University of Colorado Department of Medicine and Neurology, and was very impressed with her presentation. And then she gave a couple of talks last year, and I asked her if she'd be willing to come on and be one of our guest speakers. Of course, she was willing to do so. She works with seizure disorders, and that'll be sort of the focus today of her talk, is the use of neurofeedback with epilepsy and seizures. So without any further delay, Dr. Frey, welcome aboard. Thank you very much, and it's all yours.
All right, thank you so much. I'd like to thank Rob and Richard for inviting me today and allowing me to speak. I am an associate professor here at the University of Colorado. I am a board-certified neurologist and a trained epileptologist, and have been caring for adults with epilepsy since 2004 here in my practice. I added neurofeedback to my practice in 2012. As part of a university practice, I see a lot of patients who are medically refractory. We have a very active surgery program here, but there are lots of patients who either are not candidates for surgery or who fail surgery. And so as a group, we were looking for other options, and including pharmacologic and non-pharmacologic, that we could offer our seizure patients. And so we've been doing that with neurofeedback for the past 5 years. Today I want to talk a little bit about epilepsy, seizures, and neurofeedback. The goal here is just to really provide you with a clinical introduction to seizures and epilepsy, but even more so is an introduction to QEEG and neurofeedback training in patients with epilepsy. This is my outline for the talk today. We're going to cover 5 different topics. The first is an introduction to seizures and epilepsy, followed by some treatment options for patients with epilepsy, and then moving into more neurofeedback-centered topics. We'll start with introduction to seizures and epilepsy. And I know that probably a lot of people already know this, but these just a couple minutes to put us all on the same page I find is very useful. So when I think about a seizure, I think about all the billions of neurons that are in the brain, and I know that they communicate with each other by electrical and chemical means. In general, the electrical communication between neurons in the brain is very almost chaotic and random and very small. So in general, very highly synchronized discharges are abnormal. When the brain has a seizure, it produces spontaneous, sustained, highly synchronous discharges that persist throughout the brain and then disrupt normal brain activity. What you see on the outside, what someone does during a seizure, depends on where this abnormal discharge starts in the brain and then how much of that area is actually involved. So if we define a seizure as an abnormal, sustained, synchronous electrical discharge in the brain, we can then define epilepsy as the occurrence of 2 or more unprovoked seizures. And there's been a lot of debate within the epilepsy world of why do you wait for 2 seizures? As it turns out, not everybody who has 1 seizure will have 2 seizures. Approximately 1/3 of patients who have a seizure will actually never go on to have another seizure in their lifetime. And so if you wait for 2 or more unprovoked seizures, then you really have a brain, a patient with a proven ability to make seizures, and then there's a higher likelihood to then make more seizures. So we often wait for 2 seizures before we diagnose someone with epilepsy. It's also interesting to know how big of a clinical problem this actually is. Looking at national databases, epilepsy is actually the fourth most common neurologic disorder in the United States after migraine, Alzheimer's disease, and stroke. The prevalence of epilepsy in developed countries is between 5 and 10 per 1,000 people. So what I tell my patients is that if you're in a group of 200 people, this could be a basketball game, this could be a work meeting, there's one person in that room that is likely to have epilepsy. And I usually bring these pictures out too because there are a lot of public figures that have been diagnosed with epilepsy. And so not only are there sort of the 1 in 200 in every room, but there's probably 1 in 200 of the celebrities and the newsmakers that we know about. When we think about epilepsy, it is important to know that epilepsy is most common at either end of the age spectrum. This graph here is taken from an epidemiologic study done in Rochester, Minnesota. On the horizontal or x-axis is the patient's age going from 0 to 80, and on the y-axis is age and gender-specific incidence per 100,000 people going from 0 to 200. And if you look here, the graph is U-shaped, meaning that there is a peak of epilepsy incidence in childhood, so between 0 and 10 years old, but there's an even higher peak after age 60. When we talk about seizures, we generally talk about two main types of seizures. The first is a focal onset seizure. And in focal onset seizures, the abnormal synchronous electrical discharge clearly begins in one specific part of the brain. On the other hand, we have generalized onset seizures. In these seizures, the abnormal electrical activity is very widespread throughout the brain very early in the seizure. When we talk about focal onset seizure, we're talking about things like simple partial seizures or complex partial seizures. When we're talking about generalized onset seizures, we're talking about things like absence seizures or primary generalized convulsions. When you have a patient with focal onset seizures, a cause can be clearly identified only about 1/3 of the time. In general, this 1/3 of the time is due to various types of acquired brain injury. This data is also taken from an epidemiologic study in Rochester, Minnesota, and it shows the proportion of incidence cases of epilepsy by etiology within the studied population. And you can see that the large group, 65.5%, is labeled idiopathic or cryptogenic, which is just a fancy word for meaning that doctors have no idea why these seizures are happening. Obviously, they are happening. We just, modern medicine isn't good enough for us to be able to identify a cause. Following behind that, we also see seizures that are of vascular origin. These are generally folks who have had a stroke, who've sustained some damage to their brain, and this damage has then gone on to cause seizures. We also see seizures from congenital reasons. We see seizures after traumatic brain injury. We see seizures related to brain tumors, degenerative diseases, and brain infections. So that was just a brief introduction to seizures and epilepsy. I'm going to move on now to treatment options for patients with epilepsy. When you think about treatment options for patients with epilepsy, the clinical treatment goals generally are stopping seizures. We often start with pharmacologic therapies, and then we move on to surgery. And where neurofeedback comes in is when we start thinking about neuromodulation. One of the other treatment goals that we pursue for patients with epilepsy is to diagnose and treat the comorbidities that often come along with seizures. And the whole bottom line to doing this is to try to restore patient quality of life. When we talk about stopping seizures, we really mean that we're trying to rebalance the excitation and inhibition within the brain. And this, we'll talk about this a little bit later, but this is really where neurofeedback can come in. This rebalancing can occur at multiple different levels, the neuronal level, the tissue level, or the network level. Neurofeedback tends to work mostly at the network level, but the overall purpose is really the same. We're trying to decrease the excitation within the brain or increase its inhibition. I talked a little bit about this already, about pharmacologic therapies, and anti-seizure medications are really the mainstay of therapy for many people with epilepsy. All anti-epileptic drugs are designed to suppress electrical activity in the brain. We know that seizures are abnormal, highly synchronous electrical activity, so all of these anti-epileptic drugs are really designed to suppress this electrical activity. Unfortunately, our anti-epileptic drugs are not specific, and so they end up suppressing all electrical activity, both abnormal, which is the target, as well as normal. This may cause fatigue or additional cognitive or mood dysfunction in the patients who are taking these medications. In addition, we know that anti-seizure medications do not control all seizures in people with epilepsy. This is a pie graph that is taken from a publication from 2000, and this group of authors looked at a large group of patients with new onset epilepsy. They put them on a medication, so in this case it would be the blue segment or labeled first drug, and then they followed them to see how many of them became seizure-free on that first medication. It turns out that 47% of the patients who were put on one drug were seizure-free on that medication. If the authors then switched to a second drug, they got an additional 13% of patients to become seizure-free. And if they then had to switch to a third drug, they got an additional 5% of patients seizure-free. And they included some data about the fourth and fifth medication, but the additional seizure freedom within those groups is really quite small. At the end, they were left with about a third, in this case 36% of patients who were not controlled by medications, and these patients they labeled drug-resistant. When we talk about drug-resistant patients, we also talk about a couple different words for that are medically refractory, intractable, again, drug-resistant. These tend to be the patients who will show up in a neurofeedback clinic looking for some additional type of therapy to help control their seizures. So this is often the main question that patients have for me in my clinic. Again, I am in a tertiary referral center, and so I do get sort of the toughest of the tough cases. But the patients who come to me are often medically refractory, and they're looking for therapy options that are really beyond medications. When I talk to them about things like lifestyle modifications, dietary modifications. I talk to them about epilepsy surgery. And then most important for this audience is I talk to them about various forms of neuromodulation, including neurofeedback. And before I leap into neurofeedback, I just wanted to review what are the risks that patients face when they have intractable epilepsy, and why we should continue to pursue any option that is available and to try to control their seizures. We know that patients with ongoing seizures are at higher risk of injury. This is primarily due to drowning, burns, or accidents. There is a 25% lifetime risk of epilepsy-related death. They also face ongoing medication side effects, a risk of developing status epilepticus. Between 2 and 50% of patients with intractable seizures face declining cognition over the years. They're also at risk for psychiatric disturbances. They're at risk for SUDEP, which is sudden unexpected death in epilepsy patients. They are at higher risk for death from pneumonia, and they have 6 times the general population risk of suicide. Okay, so let's go ahead and talk about neurofeedback. As everyone knows, neurofeedback is a form of learning or operant conditioning. It uses the feedback of EEG signal to help train individuals to produce healthier brain rhythms. And by healthier brain rhythms in this context, I mean these are rhythms that are less likely to be proconvulsant or pro-seizure. In this population, we know that neurofeedback can be a powerful tool for re-regulation of dysfunctional brain rhythms, and this can result in a reduction of seizures and also in an improvement in quality of life. Neurofeedback depends on neuroplasticity. Neuroplasticity is the ability of the brain to physically and functionally rearrange itself in response to stimulation. Neuroplasticity actually occurs at a variety of levels. We've been able to document cellular changes, cortical reshaping, as well as cortical remapping. At the heart of neuroplasticity is the idea that persistent activity within the brain really creates structure. It's the basis of learning and memory as well as recovery from brain injury. And it's important to know that every experience that you have changes your brain very slightly. So I often ask myself which epilepsy patients should be considered for neurofeedback. And I really have come to the conclusion that neurofeedback should be considered for all patients with medically refractory epilepsy. Again, this is unacceptable seizure control despite maximum tolerated doses of the then 2 to 3 appropriate drugs as monotherapy. In my clinic, I also choose patients who are not candidates for epilepsy surgery or who have had epilepsy surgery and subsequently developed recurrent seizures. I like to include this in my talks too. This is from Joel Lubar, published in 1976, and he talks about the different potential quote-unquote successful outcomes when you're treating a patient with epilepsy with neurofeedback. And obviously the most the easiest one, I guess, to measure would be reduction in seizure frequency. But I've also seen patients who've reported a reduction in seizure intensity. They also report a new ability to fight off seizures, as well as an increase in length of seizure-free periods. We can also follow along their progress on the QEEG. We can see normalization of the EEG parameters. So which training protocols have been used in patients with epilepsy? When I think about this, I think that there's probably been about 5, and I divide these into different groups. The first is the SMR-based protocols. SMR stands for sensory motor rhythm. Then there's the LORETA Z-score-based protocols, the connectivity-based protocols, the SCP or slow cortical potential-based protocols, and then finally combination protocols. I'm going to talk a little bit about each of these and just review the evidence that we have in the literature, as well as some of my experience using them here in my clinic. So SMR, or sensory motor rhythm, and you guys probably know this also, was initially documented by Barry Sturman and colleagues while they were studying the neurophysiological control of sleep in cats. They noticed that when cats were awake but behaviorally quiescent, they produced a 12 to 15 hertz rhythm over the central head regions on EEG. They named this a sensory motor rhythm, or SMR, and noticed that it was also very similar to sleep spindles. In their lab, they then used contingent operant conditioning in these cats to increase their production of SMR while awake, and found that these cats were also producing more spindles during sleep. The fact that the cat's EEGs changed during sleep suggested that the SMR training during wakefulness was actually changing the underlying physiology of the brain. This group also studied the mechanism of SMR generation. They found that motionlessness in the cats, in the context of attention, alters sensory input to the thalamus and brainstem, that the reduction of afferent sensory input to the thalamus triggers ventral basal thalamic cellular hyperpolarization, followed by a calcium-mediated slow depolarization. The depolarization of the thalamic cells results in a burst of spikes that are shown here in the inset box that are relayed to the thalamic reticular neurons. Feedback inhibition from the reticular nucleus then restarts the hyperpolarization, slow depolarization bursting cycle. The bursts of activity are transmitted to the sensory motor cortex and are represented in the scalp EEG as SMR oscillations, as shown in this expanded inset box here. SMR, like all neuronal population rhythmicity, is governed by brain inhibitory networks. We've seen in recent human fMRI studies that SMR production is associated with increased metabolic activity in the striatum and substantia nigra, which is associated with increased motor inhibition output from the basal ganglia as a whole, which then may result in improved control over motor excitation. There are a number of literature references that have been published using SMR-based protocols. I've listed them here. I'm not going to review them each in depth, but you will have the slides available to you, I believe. If not, I can certainly send them out. The initial studies were done in 1974 in a patient with intractable seizures, and then the most recent studies were done in 2009. Okay, I just wanted to make one more comment about this too. The SMR that is usually trained is again trained over the sensory motor cortex. You can train at CZ. Groups have trained at C3. Groups have also trained at C4. I have found that it is best when you're training SMR protocols to train the patient over their dominant hemisphere. So I usually train over CZ or C3 when I'm trying to increase SMR. I have found when I train over the non-dominant hemisphere that I can often have an increase in seizures, which unfortunately is exactly what I didn't want. And so I've developed the habit of just training on the dominant hemisphere. In general, the frequency range is somewhere between 11 and 15 hertz. Some people have narrowed that down to 12 to 14 hertz or 12 to 15 hertz, depending on the paper that you read. In general, the SMR is enhanced or rewarded, while at the same time, either at the same place and or another place, there's a theta inhibition, which is generally between a 4 and 7 hertz frequency range. If you look at these same studies, you can get an idea of what the seizure response looks like using these SMR-based protocols. For example, in the first study, Sturman's study from 1976, 1974, they found that major motor seizure frequency was reduced in all the epileptic patients studied, and seizure manifestations were not observed before 2 or 3 months of regular and continuous training. So what they did is they went ahead and they did long-term training, and after about 2 to 3 months they began to see seizure frequency reduction. Lubar and colleagues in 1976 were the first group to study both SMR increase and theta inhibition, and they also found that 6 of the 8 patients that they studied had reductions in seizures. Some reported reductions in seizure intensity or duration, but some patients were actually seizure-free for greater than 1 month. And again, I'm not going to go over each one of these because it'll be available in your slides. But it's just interesting, I think, if you wanted to take the take-home message from these, that most of the time you get some response. I found this in my practice as well, that most of the time people do improve either on frequency or intensity measures, but it's not necessarily a home run all the time. Sturman published a meta-analysis looking at all of these, or most of these studies in 2000. He included 24 studies with 243 patients in his meta-analysis, and he found that 82% of patients had a seizure reduction of 50% or greater following neurofeedback therapy. And when I talk about this actually to my patients or to my colleagues, I usually put this in the context of what a drug study would look like, and so I've included some data here. This is a study looking at the efficacy of Keppra, which is a very common anti-seizure medication, at a dose of 300 milligrams per day. And this is comparing it to a placebo group, and on the y-axis is the percent of patients who had a seizure reduction of 50% or greater, so the same measure that was used in Sturman's meta-analysis. In the placebo group, they had a 14.4% reduction responder rate, which is again a seizure reduction of 50% or greater. In the Keppra group, it was only 39.4%. So if you compare that 39.4%, that's actually much less than 82%, making me think that neurofeedback is a real player here, not necessarily, obviously it's not a pharmacologic measure, but if you look at seizure responder measures and compare them to pharmacologic measures, that it's a real player here, and you can get extra efficacy really above and beyond medications. There was a more recent meta-analysis published in 2009 that was a little more stringent with their study inclusion criteria. But again, they found that 79% of the patients who were treated with neurofeedback therapy experienced a statistically significant reduction in their seizure frequency. We do know a little bit about the predictors of response for SMR-based protocols. For example, in one study, tonic-clonic and myoclonic seizures were the most markedly reduced. Lubar and colleagues felt that SMR training seemed to be best for seizures in which there is prominent motor involvement. In the paper published by Lance and Sturman in 1988, obviously, seizure reduction was strongly associated with acquisition of the EEG training task, but they also found that patients who responded better tended to be on a lower number of anti-epileptic drugs. They also had a more normal profile on the MMPI and the WPSI. More successful subjects also performed better on the Wonderlic and worse on tests with strong motor components. It was also really interesting that there were no seizure variables that predicted training success. So type, site, duration, frequency, and age at onset really had much less predictive value than these other factors did. So we're going to go ahead and move on to LORETA Z-score-based protocols. But before I do that, I want to talk a little bit about some work that was done by Walker and colleagues. They did single or dual channel training in their patients with epilepsy, and it was really a step away from the many SMR-based protocols because they chose the channels to train based on the QEEG. Again, they used QEEG parameters to choose both training areas and frequency bands, and they trained the most deviant power and coherence abnormalities first. The chosen parameters were done one at a time, and they had about 5 to 10 sessions of each protocol, and they had similar response rates to the SMR training historical controls, although they did not have controls in their own published data. So if you look at LORETA Z-score neurofeedback versus single or dual channel training, one of the main differences is that you're now training on an inverse solution. When I talk about that, I usually tend to give people sort of a basic neurologist understanding of an inverse solution, because I certainly don't have a mathematic understanding of the inverse solution. But basically, when you collect EEG using scalp electrodes, each scalp electrode is actually collecting data from a number of different brain regions, both directly under the electrode as well as widely scattered around the brain. So if you're just looking at that one electrode channel, you're actually looking at quite a bit of data across multiple different brain locations. What an inverse solution then does is mathematically it takes that data and tries to reassign the data to the specific brain regions that it's coming from. In this way, if you train on the inverse solution, you can actually reach deeper structures and you can be more specific about your targets for the neurofeedback training. Most LORETA training protocols also use Z-scores, although they're not unique to these protocols. But Z-scores then provide a uniform measure for both power and coherence abnormalities, and can potentially prevent training too far in one direction. So there's really been just 2 papers that have been published using LORETA Z-score-based protocols in patients with medically refractory seizures. These were both, one was published in 2013, one was published in 2015. And I know the data best from the one that was published in 2015 because it was done on my patients. And in that study, I trained patients using the default mode network. This is a picture of the default mode network. It is a spatially distributed network of brain areas. It includes areas such as the posterior cingulate cortex, the medial prefrontal cortex, the precuneus and lateral parietal cortex, that are most active during conscious rest and less active during cognitive tasks. The default network, again, preferentially activates when individuals focus on internal tasks such as daydreaming, envisioning the future, retrieving memories, engaging others' perspectives. It's negatively correlated with brain systems that focus on external visual signals. If I wanted to train the default mode network using a LORETA Z-score neurofeedback, these are generally the Brodmann areas that I would be using, and you can see that they really are broadly distributed, but they match up to the areas that were seen on the fMRI maps that I just showed you. So why might the default mode network be a good training target in patients with epilepsy? We know that through functional MRI studies that there is abnormal connectivity within the default mode network in patients who have focal onset epilepsy. We also know that there's abnormal connectivity within the default mode network in patients with primary generalized epilepsy syndromes. And we also know that not only is it sort of at baseline resting that there's abnormalities within the default mode network, but we also know that when the brain is actively discharging with intra-ictal epileptiform discharges, that this then suppresses default mode network activity. Based on these fMRI studies, the default mode network might be a good training target. It may actually be a counterbalance to intra-ictal epileptiform discharges or even seizures, trying to again increase that inhibitory wall as we rebalance the brainwaves in these patients. We have a little bit of data about seizure response using LORETA Z-score-based protocols. Koberda published in 2013 that most of the patients that he treated had some improvement in seizure frequency. And in our paper in 2015, we showed that 5 out of 6 patients had a notable reduction in seizure frequency. So again, there's sort of a theme coming out here that most of the patients get some improvement, but it's very rarely a home run. I'd like to talk now a little bit about connectivity-based protocols. Most of the connectivity-based protocols that have been studied in patients with epilepsy are based on coherence. I'm sure you guys know this, but just to make sure that we're all on the same page, I define coherence as a consistent phase relationship between 2 or more signals. Coherence can really be defined for any frequency component or bin, and it's independent of the absolute phase separation between the 2 signals. It's also independent of the individual amplitudes of the signals. In general, reduced coherence is suggestive of reduced functional connectivity, and elevated coherence is suggestive of reduced functional differentiation. So the references of this are really coming out of Rob Cubbin's work, and he feels that coherence hypoconnectivity may indicate that the balance of excitation and inhibition is off. The way I think about it is when you're hypoconnected, it means that there's a part of the brain that is just doing whatever it wants. It is not well connected to the brain that's around it, which means it's not well inhibited by the brain that's around it. And so the brain region that's doing whatever it wants could clearly be a seizure focus because it's not really responding to the inhibitory signals that are coming from the rest of the brain. So when he treats these patients, he seeks to enhance the coherence of these hypoconnected networks. He identifies the hypoconnected networks by analyzing the patient's interictal epileptiform activity or spikes. He does not recommend training to decrease coherence and has actually seen this increase seizures in some patients. But he has not seen any abreactions, again, if the coherence is trained up. Okay, I wanted to talk a little bit about SCP-based protocols as well. Just again, so that we're all on the same page, slow cortical potentials are slow waveforms that occur in the EEG, lasting 300 milliseconds to 1 or more seconds. They occur in reaction to a stimulus or in reaction to the expectation of a stimulus and tend to be a measure of general electrical activity in the brain. Because these potentials are so small, you have to average this over many trials, and they're thought to be generated by large cell assemblies in the upper cortical layers. This is important for patients with epilepsy because slow cortical potentials are thought to reflect the overall level of cortical activation in the brain. SCPs that are negative are thought to represent greater depolarization or an increase in underlying cortical excitability, and positive SCPs are thought to reflect less depolarization, oh sorry, I have a typo there, or a decrease in underlying cortical excitability. We know that patients with intractable epilepsy have a decreased ability to regulate this cortical excitability, and in theory, learning to control their SCP generation may help restore that ability. If you look at studies that have used SCP-based protocols, about 2/3 of patients who actually learn to control their slow cortical potentials will have some effect on their seizures. This is true even for patients who have drug-resistant epilepsy. In one of the studies published in 1998, again, we have a few predictors of response for the SCP protocols. And this group of authors noticed that patients who consistently were able to produce large negative SCPs during training were much less likely to experience a reduction in seizure frequency. So again, these negative SCPs are representative of higher cortical excitability, and so it makes sense that you actually wouldn't experience a reduction in seizure frequency. But on the flip side, patients who are able to produce positive SCPs were more likely to experience a reduction in seizure frequency. And again, these authors, like authors that we've talked about already, found that age, medication, seizure history, and seizure focus were not necessarily predictive of how patients would do when they did SCP training. Okay. I'm going to go ahead and move on at this point to the last topic I wanted to cover today. And I'm asked this quite a bit by people, and so I just wanted to review it, whether or not there are any specific findings in baseline QEEGs in patients with epilepsy. And this could be looking at it from a diagnostic standpoint, which we really don't have that much information about. Or looking at it from sort of an expected finding, how am I going to build my protocol for this patient? So when you look across studies that have actually looked at this question, you find that maps of individuals with epilepsy may show a focal increase in absolute or relative theta range activity. In general, this can be at the seizure focus, but not necessarily. We also find that QEEG mapping may be of higher yield in detecting abnormalities than routine visual EEG interpretation alone. You may also see changes in brain connectivity, and this really comes out again from Rob Cummins' work, particularly hypocoherence. So again, you're looking for that area of the brain that is not connected well and not responding well to the inhibitory input from the brain around it. We've also found that QEEG changes may actually be widespread, and they can actually be far from the suspected seizure focus. So even though you may have a theta focus or a hypocoherence focus, be a little reluctant about assuming that that is where the seizures are coming from. That may be a compensatory or related QEEG change in this brain that has epilepsy. This again is a list of different studies that have really looked at this. I'm not going to go over this in depth because we've already talked a little bit about the take-home messages, and this will be available to you again in the slides. And that's really what I wanted to present today. That does leave us with about 15 minutes for questions. Is it possible to go ahead and unmute people so that they can ask questions?
Well, we should try and do that. And in the meantime, for folks, I do have the PowerPoint. I will be sending that out on the listserv in just a few minutes. So
that would be great. Thank you.
To it. Yep, people will have that. And I had somebody knock on my door. And I may have missed this. If I did, I apologize for asking this question, but you were looking at all the different neurofeedback protocols and types of neurofeedback. Was there one or two that stood out to be most effective in working with seizures?
I think that's something that we actually don't know yet. We have the most data about the SMR-based protocols because they've been around the longest. There have been really no head-to-head comparisons and really even no observational data, and it's really hard to sort of take results from one type and compare it to results from another study when the population is not the same. I know that I've talked to you a little bit about this already, but what I'm trying to do here actually is put together an observational database of people's experience using really any protocol in any epilepsy patient to try to see if we can't collect that data and maybe get a better understanding of number one, if there is a type of protocol that seems to work better in patients with epilepsy, but number two, to try to figure out if there are any predictors, whether it's related to the patient or whether it's related to their epilepsy, that could help guide protocol selection. Because right now it's just a little bit of trial and error trying to figure out, well, who's going to respond best to which protocol, and oftentimes you sort of start one and then you have to change it, and it would be really nice to have that information available kind of at the get-go. So we're trying to put that together, and I'm hoping that, you know, as I'm certainly going to bring whatever data we have to the ISNR meeting this year, but just try to continue to collect data and see if we can't answer some of these questions.
All right. Thank you. Did we get everybody else unmuted, Richard?
We're actually making progress. It's been slow going, but we're getting there.
Okay.
I've got a lot of people that I'm starting to get there.
Now that I'm
I have a
unmuted,
question, Dr. Frey. What's the, this is Martin talking, what's the primary goal of your present study you're working on?
So the observational database is to collect the experience of the many practitioners that are treating patients with epilepsy, to collect their clinical experience, and then again try to mine that experience for possible predictors or other data points that can inform both prognostic counseling as well as protocol choice as we move forward in treating these patients.
I'm asking this question for the following reasons. We do have, to my knowledge, quite a few people who are working with epileptic or seizure patients. Would you be interested in having those members of the group contacting you for information?
Absolutely, and actually my contact information is on the screen right now, and probably the best way to reach me is to go ahead and send me an email, and as we're putting together the final touches on the research infrastructure right now, and so I am happy to have any and all people who are interested to contact me, and I can send them more information about it.
Thank you very much, and I must say this is a very helpful presentation for me.
Oh, thank you.
Thank you. I admire your well-structured information. It's extremely helpful. Thank you.
Thank you.
Okay, do we have anybody else with a question?
yes, Mike Sitar, I want to comment. It was a very well organized. I appreciate you putting all that historical research into a structure where it's retrievable. That's very clear. I've got a question on the ketogenic diet. When I first heard about it, it was only for kids. Has it been expanded and used with adults now?
Yes, you can use the ketogenic diet with really anyone. The trick is to maintaining the diet. So it is very strict and it's often unpalatable. And so I found in my practice that nobody who actually chooses what they eat can maintain the ketogenic diet. And so it's best maintained really in children whose food is chosen and given to them by their parents, or in adults whose food is chosen and given to them by a caregiver. I really haven't had anyone who's deliberately been able to follow the ketogenic diet. That being said, oh, I'm sorry.
No, what makes it unpalatable?
Well, it's often because of the high fat content. You're often eating things like 2 sticks of butter for dinner, or a cup of mayonnaise with a cup of cream for dinner. And it's really difficult for people who choose their food to maintain something like that. We do have some emerging data suggesting that a similar idea, which is called the modified Atkins diet, can be effective in both children and adults with medically refractory seizures. The modified Atkins diet is also a high-fat diet, but there's not quite as many other restrictions, and it tends to be much easier to follow. And so patients who approach me with dietary requests, I often steer them to the modified Atkins diet.
Thank you.
Hi, this is Funda. I'm just very curious now that we mentioned ketogenic diet. Would you recommend it to people who are healthy, who have no seizure problems, if they can stay on the diet? It seems a little stressful to the body to me. Is that my bias?
No, it's not your bias. It is a very stressful thing to the body. It can result in electrolyte and other metabolic abnormalities. It puts you at greater risk for extreme weight loss. It puts you at greater risk for kidney stones. And so I usually do not recommend it unless I have a clear indication that I think somebody will clearly get benefit from it. Because you are, like many medical decisions, you're weighing the risks and the benefits of an intervention, and you want to make sure that in interventions that are pretty risky, which this is, that you're going to get a benefit from it that outweighs that risk.
Are there any data related to pseudo seizures and treatment with QEEG?
So there's one paper that I'm aware of, and I'm sorry I can't come up with the authors right now, that looked at QEEG findings in patients with functional neurologic disorders. And then there's one case series that was published by Paul Swingle and colleagues who did neurofeedback training in patients with non-epileptic seizures. And that was published, I think, in the 80s, I want to say. And they did find some benefit for it. It's important to note, though, that their neurofeedback training was done in the setting of a very comprehensive multimodality psychological intervention. So it wasn't just neurofeedback. It was multiple other things that were being done at the same time.
Could you quote that article, the latter, again, please?
It was Paul Swingle was the first author, and I think it was sometime in the 80s. I want to say it was 1988. If it's okay with Rob, I can pull both those articles and sort of send them to him to send to the group.
That would
Be very glad to do that. Anything
Okay.
you want to send along, send it to me, Lauren, and I'll get those out to everybody. I'm sending out the PDF of your slides as we speak.
Sure, thank you.
No problem. Thank you.
Hey, Lauren, this is Honey. I have a question. You mentioned neurofeedback for medically refractory. Is there any kind of barrier in terms of trying to do this with the entire population and as a more of a first line intervention?
No, there's no barrier to that. I do caution patients who ask me that all of the studies that have been done with neurofeedback have been in patients who have also been on seizure medications. And I find that the combination tends to work best. And I think that's because when I look at seizure brains, I see that there's sort of two competing forces. So there's the seizure force, which is a disorganizing force, and there's the neurofeedback force, which is a reorganizing force. And I feel like that the medications help. They don't really help the neurofeedback part, but they reduce seizures to the point where the neurofeedback can actually be helpful. And so most of my patients, I do recommend that they be on some kind of anti-epileptic medication and use the neurofeedback as an adjunct therapy.
Well, thank you.
Can you comment on any people who've been able to reduce their load of medication with neurofeedback added to the mix?
Yes, so that was found and commented on in a number of the published studies, and I've also found that in my practice.
Right.
That, I will have patients who come in on 4 medications, they do the neurofeedback training, and they go out on 2. So I haven't actually been able to get someone off their medications completely, but I have gotten them to the point where they can reduce it and then reduce the side effect burden that they have from the medications.
In your research, are you going to be asking people if they're doing any breath work or breath training or HRV along with the neurofeedback? reason I'm asking is about 45 years ago, a colleague of mine in one of the training hospitals was reporting a case she worked with where the person had auras, and she was training the person to do slow, deep breathing at the sign of an aura, and was able to reduce the incidence of seizures using breath work.
That's a really good question, and yes, we will be asking providers to report if they've done any adjunct therapies along with the neurofeedback.
Great.
This is Funda. I thank you for your previous answer. I'm wondering if you have any ideas, preferences about using games versus movies or looking directly at wave signals.
I've tried a number of different things in my clinic, and I find that at least in epilepsy patients, that they respond best if the reward stimulus is very, very simple. So I use just a green circle on the screen. I use NeuroGuide software most often, and so it's a green circle on the screen. I don't know that that is generalizable to all patients with epilepsy, because I tend to see the worst of the worst with a lot of cognitive dysfunction, either from their epilepsy or from their medications. And so I often find that if I give them more complex rewards, that they are spending some of their brain energy keeping track of the reward. So keeping track of the movie, or keeping track of the song, or paying attention to the reward as more than a reward. And so I've often sort of backed off then and just really used the very simple rewards. But again, I'm unclear about how generalizable that's going to be to all patients with epilepsy, and certainly not to all patients who seek neurofeedback.
Thank you.
That's a good point. I'm glad you asked. I remember the patient I had years ago who had perturbations after a head injury, and if she was walking and came around the corner and there was a strobing school bus or a emergency vehicle, her knees would buckle, and she could not look at the old CRT tubes, and even the newer screens were bothersome to her visually. And she did a workaround because she was a graphic artist, and used a projector to project what she was working on the computer onto the wall, and the refresh rate was different with that. So that might be something else to take a look at.
That's a good idea.
All right. Well, we're at the top of the hour, folks, so we're going to let Dr. Frey get back to her work, and all of us get back to our working patients. Thank you so much. Great presentation.
Thank you.
Send the papers
Thank you.
along, and I'll send those out to our group. By now, everybody, because I got my copy of it already, everybody should have the email that has the the slides from today. If for some reason it doesn't go through for you, just email me, back channel me, and I'll send them to you directly. So Lauren, thank you so much.
Thank you so much for inviting me.